case 3.
I can do this one.
Okay.
So looking at it from this far away, the epi looks pretty normal. It looks like most of the pathology dermis. And what you can see is there's kind of a homogenized pinkness to the dermis. And then when we go in a little further, this looks pretty good for amyloid. You can see some cracking in it as well as some pigment incontinence. And so for this, I would say macular amyloid.
Yeah, very good. This is sometimes incredibly subtle, and unfortunately, I mean, this is not, as a scan goes on this system, it's not too bad. But I mean, even with the best of situations, this can be something that's pretty subtle. You have to often, if you're really good, you might notice it at low power, but usually you have to go high power. From low power, I would say this is one of the invisible dermatosis, situations where the skin looks normal or almost normal in many cases. From lower power, it's usually on like the back. You'll have like pigmented patches or thin plaques on the upper back. There's debate about what causes macular amyloidosis. I think a lot of the times my understanding is that people have attributed it to some degree of rubbing or chronic irritation change. And so what you get is deposits of pink amorphous material in the papillary dermis. And let's see, there's a little bit more over here. And sometimes it's hard to tell this apart from just normal papillary dermis or from basement membrane. That could be a little thickened in some situations. So here's what's going on here. Oh, and by the way, the deeper reticular dermis here does have a little bit of blue stuff, probably just solar elastosis. I guess you could also think of mucin, and it's hard to tell the difference here on this scan, but I think it's probably just some solar elastosis. But in many cases, the rest of the dermis looks totally normal, no inflammation. But the material here is pink, it's homogeneous, it's pale, and it has little crack artifacts between it, like amyloid typically does. This is not associated with light chain amyloid or systemic amyloidosis, okay? Really important to remember that. And in fact, when I make a diagnosis of macular amyloidosis or the closely related entity Lichen amyloidosis, which I'll mention in just a minute, those are both keratin-derived amyloids. So what happens is the keratin and other proteins from degenerated and dying keratinocytes drop out from the basal layer, deposit in the papillary dermis, and what comes along with them is the melanin pigment that is normally stored in the basal layer keratinocytes. See right here, these pigmented brown cells, as most of you probably know, but any beginners watching online, the brown cells in the basal layer are not melanocytes usually. They are actually keratinocytes. The melanocytes make the melanin. This gray guy right here in the middle, that's a melanocyte. No melanin that you can see. They make the melanin, but then they feed it to their neighboring keratinocytes. The keratinocytes store it. But when the keratinocytes get injured or die, and you can see one dying right there, that orangey looking keratinocyte with a shriveled nucleus, that's a apoptotic keratinocyte, necrotic keratinocyte, dyskeratotic keratinocyte. Sometimes once the nucleus goes away, people call them cytoid bodies, savate bodies. All these different names all mean dead keratinocyte in the epidermis, okay? We just have to have 55 names for everything in dermpath, okay? So what happens, they die, and then their keratin falls into the dermis, and it gets all clumped together here, and those cracks between it are present. Here's nice cracking artifact. I find that really helpful, the cracking artifact, and like you very nicely said, the pigment gets trapped in the middle because the pigment and the amyloid are both coming from dying keratinocytes. The pigment, melanin pigment, gets trapped in between these dying keratinocyte fragments, and it gets all smushed together in the papillary dermis, and that is the evidence that it's keratin amyloid, the fact that it's in the papillary dermis and the fact that it has melanin pigment trapped in between it, okay? On staining, it will often stain similar to light chain amyloid, but the location is different, okay? So they'll stain like very nicely, supposedly with Congo red. I find Congo red very difficult stain to get to work correctly, to be quite honest. I much prefer thioflavin T, but you have to have a fluorescent microscope to examine it, but it glows beautiful bright green on thioflavin T, just like regular light chain amyloid does. The difference is that it's here in the papillary dermis and has the melanin, whereas systemic amyloidosis, the kind that's associated with light chains and with plasma cell neoplasms, is going to usually be down in the deeper dermis around blood vessel walls, okay? Or sometimes making a big diffuse nodule filling the dermis, but not just limited. I've never seen a case of systemic amyloid that was associated only with the papillary dermis. In my experience, I've never seen that. So whenever I make a diagnosis of macular amyloidosis, I say this is keratin-derived amyloid. It is not associated with systemic amyloidosis or light chain amyloid. Because I have seen people before that got referred into an amyloid center and were sent for a bone marrow biopsy because of a diagnosis of macular amyloid that the treating doctor, probably a non-dermatologist, did not understand was totally unassociated with systemic amyloid. So after seeing that one time, I ever since started adding to my reports just in case any non-dermatologist or patient reads it and freaks out thinking amyloid, because amyloidosis, systemic amyloid, is a terrible disease that's very problematic. So I like to make sure people know this is a benign condition that may be annoying, but is not associated with a life-threatening disease like systemic amyloid. Now, lichen amyloidosis is a similar, exact same kind of process of dying keratinocytes and amyloid and pigment trapped in the papillary dermis, but it usually is on the anterior lower legs, on the shins, and it's usually more abundant amyloid and associated also with reactive epidermal hyperplasia, papillomatosis, hypergranulosis. It basically has like lichen simplex chronicus changes in the epidermis plus amyloid in the papillary dermis, and usually it's very itchy. People scratch and pick at it, and I've had people comment on it. I've got another video that mentions it online, or I posted it online once, I can't remember, but some people have responded and said it's a very unpleasant condition to have. So again, unpleasant, morbid, definitely problematic for the patient, but not associated with systemic amyloid. All right, so that's a good one to know. I know we talked about that at length, but it's important because it can get mixed up, and it's also hard to identify at first glance. And the one last thing is a lot of people in books like to talk about, because it's keratin-derived, you can stain it with keratin immunostains, particularly like CK56, like a high molecular weight keratin. I have tried that over the years. I have found it to be disappointing. It does give you some staining, but I find that not all of the amyloid stains. You might get some little fragments of staining in there, but I often have tried it, and I have not found it personally to be that helpful, and it doesn't look as good as I would expect that it would. So in any case, I think part of the reason is that the amyloid is not purely composed of keratin. I always was under the impression that it was, but upon further investigation, there are other proteins that get mixed in there with the keratin, is my understanding. So there you go.